Welcome back, everyone, and thank you for being on time. I know there was quite a long line downstairs in the lunchroom, so good job for everyone for getting back here. If you are joining us for the first time today, just a couple reminders, and one, conference materials are available on the CTEO website, and it includes the fall conference guide, the presentations, and also participant instructions and survey instructions. The survey instructions include links and QR codes for the Ask CMS Live question survey. So those of you that are viewing via webcast, if you have a question, please go to that link and send in your question, and we will address it during the open Q&A portion of our event today. Also, there is the participant feedback survey that we would like you to complete at the end of this event. And lastly, the CCB attendance survey. To provide feedback on today's event, you will go to the post-conference participant survey. And this morning when you checked in, those of you in-house, you got a little card with a QR code with your badge. That is for the participant survey. You may have noticed when you came back that there was another card with a QR code on your table, and that one is for the CCB survey. So if you want to get CCB credits, that is the one you will use to complete the survey for the CCB credits. And just a note that that survey would need to be completed by May 20th in order to receive credits for attending today's event. Okay, and oh my gosh, you guys are way ahead of me. And I have just a quick polling question here for all of you after coming back from lunch, and that is, which emoji best represents how you are feeling now after lunch? And hopefully there's not too many who are responding D, but after standing in those lines, you might be. Oh, some sleepy people. Time to wake up. All right, but we got lots of happy and energetic people out there too, so good job, everyone. Welcome back. So I'm excited to introduce our keynote speaker for today, the Principal Deputy Administrator and Director for the Center for Medicare. Please help me welcome Dimitrios Kozoukis.
I guess the emoji are, we'll do the emoji again, but not during the speech. So good afternoon. It's great to be here with you all today, both here in the room in person, and then also live across the country. I know that we've got always a big turnout, at least for the live stream, and then also here in the room for these conferences. It's an opportunity for us to share with you some of the newest developments and key points for the Medicare Advantage and Part D programs for the upcoming year. And I know that you heard from the administrator this morning. It was sorry that she couldn't be here in person, but her video remarks, I think, gave you an unambiguous picture of the administrator's vision for the Medicare Advantage program and the Part D program. I'm honored to build on her remarks and describe in greater detail the critical steps that the administration has taken to modernize Medicare Advantage and to provide new flexibility to meet the needs of patients. So in my role here at CMS, I've got a long title, but it really amounts to two things. One is to support the administrator and her leadership of the agency, particularly with a focus on Medicare and the many changes we are making to the program. These are things I've talked to this group about in the last couple of years in this forum and others. And the second is to lead a talented and hardworking staff that you've had a chance to hear from, I think, and meet as well during this event, as well as previous iterations of it. And that team develops policies and manages the operations of the program. The job is really an incredible one, and it's humbling in many ways. And I want to tell you a little bit about why. Maybe just here in the room, can I ask, How many of you have a family member or a loved one who is a Medicare beneficiary? Okay, so for those of you who are watching remotely, every hand in the room went up. That's what makes this job really important and what makes it really quite a challenge. And not only because the Medicare benefits that we provide are worth $678 billion to 56.8 million beneficiaries each year, and not only because on the fee-for-service side we process 1.2 billion claims, but because everywhere I go and I ask that question, everyone raises their hand. And it's one of the principal ways in which people encounter and experience the government is through the eyes of the Medicare program. And it really brings home to me the fact that the decisions that we make in this, amongst this team in this building, and another one over in Washington, D.C., has so many real impacts on all the people that are important to us in every family, in every household, and in every, really for everyone in America. So it's critical that we make the good decisions and the right decisions, and that we approach it with a level of humility that this responsibility provides. For me, it's personal. My father dealt with chronic illness as far back as I can remember, and I sometimes joke that the Medicare program has been a member of our family for a long time. So it's sort of really a sort of odd circumstance of life that I got to now have this opportunity to help lead the program. And in carrying out that responsibility, my mind always goes back to all the times when my family encountered a healthcare system that's so complicated and so often seems to array everything against the patient's wishes and the patient's needs, with the difficulty in encountering and dealing with the healthcare system. And this isn't specific to Medicare, it's really just a broader statement about the healthcare system that we have in America today. And as we consider how we can make changes to the program and the system, my mind always goes back to the writings of a judge, actually, in D.C., who wrote, "Picture a law written by James Joyce and edited by E.E. Cummings, such as the Medicare statute, which has been described as among the most completely impenetrable texts within the human experience." It's certainly a laugh line, but the fact is that we struggle with that law every day. We work within the confines of it quite diligently to make the program as effective as it can be for people and to provide and empower people to make choices for their health care. And as we look at the program, and particularly the lens that this administration is taking to it, what we're focused on is ensuring that we end the sentiment or feeling that people have that the deck is stacked against them. That in a time of personal health crisis, when everything's on the line for patients and their families, in the most vulnerable moments of their lives, that the options for what care they get and how to get it are determined too often by Washington rules, by impenetrable text and the like. And so that's the spirit with which we've taken to make changes to the programs. We believe that generations of government policy have failed to produce the results that our citizens demand and require. And so we're taking a new approach. And that approach is to put patients in the driver's seat of our healthcare system and equip them with the information and the freedom to determine value for themselves. Medicare Advantage in particular provides an ideal vehicle to do this. It offers beneficiaries the opportunity to pick from a large selection of plans based on what offers the best value for them. So this administration has taken action to allow plans to compete to offer even greater value for beneficiaries customized to each of their needs. I want to work through a few highlights and examples so you have a clear picture of what we mean at an individual level with regards to the changes we're making. Example one. At the start of this administration, I heard a story about a patient which may contain in one situation everything I want to talk to you about. It was a patient who had a palsy of some kind. The patient had difficulty opening pill bottles. If she got a new bottle of pills and there wasn't a caregiver or someone she was seeing that week who could open them for her and her condition was acute, she couldn't open the new bottle. As a result, she ended up in the emergency room at times. It seemed, though, that there was a solution, an inexpensive pill bottle opener, and with that she could manage to stay out of the hospital. We talked to a plan who wanted to provide the patient with this pill bottle opener. to make it easier for the beneficiary to take their medication. Seems pretty straightforward, but not so fast. When the plan checked with its lawyers, they were told they could not proceed unless they made the tool available to nearly everyone in the plan. The rule stacked the deck against patients. It told patients what my kids' preschool teachers told them. You get what you get and you don't complain. Any doctor will tell you that each patient is different. Some of them require assistance that's not necessary for others or not as helpful for some. Recognizing this basic fact, we changed our rules so that plans can now provide disease-specific benefits. So that beneficiary who needs the extra help from a pill bottle opener can shop for a plan that helps them, and plans can compete for their loyalty by providing tailored benefits. Another example. This one relates to a situation many of you in the audience might be in. So many of us had the good fortune to be loved and cared for by our parents as children. They cared for us when we were ill. They helped us when we were helpless. They taught us how to respect ourselves and our communities. As mom and dad age, maybe both of them rapidly decline at the same time, or maybe we lose a parent. And so it comes to pass, if you're in the sandwich generation, that you find your roles reversed and you're taking care of your parents. You wonder how they manage to do it for you. You know they need help, and you're happy to help, but you find they sometimes need more assistance than you're able to offer. You're falling further behind on your daily tasks. If only you could just get an afternoon to catch up or take care of something in your personal life, you can make sure they get the daily care they need to stay at home or avoid a doctor's visit or a hospitalization. Your parent has Medicare, but the rules of Medicare say Medicare will pay for the hospitalization, but not what your parent needs specific to the situation to help them. Here again, the deck is stacked against people. We changed that. Medicare Advantage plans are now able to offer respite care to beneficiaries. This means that plans can send a caregiver to tap in for a beleaguered caregiver so they can quickly go back to helping mom or dad. Example 3. Does everyone remember the Apple computer commercials from about 10 years ago? The one where there was a hip young dude and then another person that looked maybe like me in a suit? I'm a Mac and I'm a PC. Or maybe you're a little older and you remember the Folgers taste test commercials. Well, we didn't let MA plans run commercials like this. Why? I have a hard time knowing. It makes no sense to me. You see, classic commercials like these help beneficiaries make direct head-to-head comparisons between their plan options. And if beneficiaries are going to be able to customize their Medicare experience, they need to know what their options are and the benefits and risks associated with those options. We made changes to our marketing requirements so that beneficiaries can engage in these head-to-head comparisons and be better informed about the choices they have. Example 4. Consider a beneficiary who 10 years ago was very active but is now homebound due to aging and disease. The transportation benefits that Medicare Advantage can offer, but are not available in fee-for-service for Medicare, by the way, aren't enough for these beneficiaries to receive the care they need. But telehealth offers a great solution for these beneficiaries. Patients in the private sector can pull out their phones, open an app, and be FaceTiming with a doctor in about 5 minutes. I've done this at home. It was really hard to believe that it was that easy. And I know that for seniors, at times it can be a bit of an extra challenge, but the fact is that as baby boomers are aging in, they have greater facile use of technology. But for Medicare patients, the deck has been stacked against them. We're changing that. With the help of the last Congress, starting next year, we are removing disincentives for Medicare Advantage plans to incorporate these services into their benefits. This will help beneficiaries utilize these tools more easily and readily than ever before. Because when patients are in charge, patient-driven care can mean just staying at home and making the care literally drive to you. We were even able to find ways within the fee-for-service program to make changes within that system so that patients can do something similar with their existing physicians for virtual check-ins. There are countless examples like this throughout the morass of federal laws and regulations and guidances that we're working to streamline and simplify every day. They include new flexibilities to increase access to important and supplemental benefits beyond the more common dental and vision, to OTC items, meals, nursing hotlines, transportation, adult daycare services, in-home support services, and so many other innovative benefits, all offered with competition at the same cost as fee-for-service Medicare. So far, we've seen many Medicare Advantage plans take advantage of this flexibility in its first year, and the guidance we released this year builds on these changes with additional flexibility for chronically ill patients, so we should see even more choices. Our vision is for plans to be able to design new benefit packages and provide services to keep people healthy and independent. This is one of the most significant changes made to the Medicare program in its history, and it will have a major impact, I'm certain, on improving health outcomes. I hope the examples that I gave you give you a good tour of what we're doing to empower patients by putting them in the driver's seat and using competition to create tangible results for beneficiaries. Speaking of results, the early results are already in, and it's clear that choice and competition are working. For 2019, CMS estimates that Medicare Advantage monthly premium declined by 6% from 2018. Approximately 83% of MA enrollees have the same or lower premium in 2019. About 26% of enrollees staying in current plans saw their premiums decline in 2019. Beneficiaries are exercising choices. Enrollment in Medicare Advantage is projected to increase by 2.4 million, or by 11.5%, from 20.2 million in 2018. Based on projected enrollment, 36.7% of Medicare beneficiaries will be enrolled in MA in 2019. 99% of Medicare beneficiaries have access to at least one health plan in their area, and all Medicare beneficiaries have access to a standalone prescription drug plan. The average number of Medicare plan choices per county increased by 5 plans. Due to new flexibilities available for the first time in 2019, not counting the flexibilities we have implemented for next year, nearly 270 MA plans are providing an estimated 1.5 million enrollees new types of supplemental benefits. So there we have it. Lower prices, more choices, growing patient satisfaction. The results speak for themselves. And as much as I'd like to pay homage to the audience, the congratulations and the credit goes not to the government or the plans, but to patients for exercising choice and driving competition. Administrator Verma has said, the solution to our problems is right in front of us, and it's all of us coming together, not relying on the government, to transform our healthcare system to make it more sustainable for today and for future generations. So, as Administrator Verma said, the answer I submit is staring us in the face. It's those loved ones that you thought about when you raised your hand earlier. Those Medicare beneficiaries are driving change through greater choice and competition. All we have to do is provide as many choices as possible to them and get out of the way. So, thank you for your time, and I hope you enjoy the conference today.
We would like to thank Demetrios for joining us today and sharing those insights and the continued vision. Our next session features a panel of speakers who will provide participants with an understanding of new rules related to dual eligible special needs plans, codified in Part C and D rule. The session will also highlight the policy and legal context for making these updates to the regulations, the specific regulation changes and operational considerations as CMS and states move forward with implementing the final rule. The final rule was still being updated as we were planning for this event. And as a result, we are extending this session for an additional 15 minutes for the presenters to share some additional information related to those updates. So, from the Medicare-Medicaid Coordination Office, please help me welcome Vanessa Duran, Marna Metcalf, Akbar, Paul Precht, Mark Steinberg, and Toby Oliver.
We'll get started in just a minute. I don't think my clicker is working. Next slide, please. Good afternoon. My name is Vanessa Duran. I am here with a really fantastic crew of folks. from the Medicare-Medicaid Coordination Office. We're going to be talking a little bit to you about the work that we've been doing since February of 2018 to implement the D-SNP-related provisions of the Bipartisan Budget Act of 2018. There's a lot going on in the dual eligible space right now, so we will be focusing particularly on the Part C and D rule that was published in April 16th of last month. But you guys have already gotten started on this, on the polling questions. So many of you were sleepy. I want to make sure that you were bright-eyed and bushy-tailed and that we knew who we were talking to. So we were wondering how many of you were representing D-SNPs, non-MA plan D-SNPs, PDP, or another organization. So it sounds like we have a fairly mixed crew here. Obviously, all are welcome, and we're really excited to share these updates with you. Okay, next slide, please. So there's a
Excuse me.
Yep. There's a lot in the final rule. We're going to get to that first slide in a minute. Perfect. We're going to just start off.
It was turned off.
Thank you. We're going to start off with a summary of the Medicare-Medicaid integration requirements in the BBA and sort of walk you through a little bit about what we've done with new and revised definitions in the rule, as well as updates to MIPA contracting requirements, and a new provision that we've established to require D-SNPs to provide assistance to their members on Medicaid coverage issues. We're then, and Marna's going to help me out with that. We're then going to move things down to Toby Oliver and Mark Steinberg, who are our appeals and grievance experts, and they're going to be walking through all the different provisions for unified grievances and appeals that we implemented in the final rule. And then, because Paul Precht is our main person on D-SNP issues in the office and has been for a number of years, he's going to join the fun and help us answer any questions that you guys have, either after our presentation or in the session that we have, the Q&A session after we conclude. Okay, so there's a lot to unpack here, and you may find this chart to be a helpful synopsis of the new requirements. I'm not going to go through it line by line because that would be boring, but it's mostly here as a reference document to help you understand a couple of things. One of those things is that not all provisions apply to all D-SNPs, and we will walk through the various provisions and let you know which subsets of D-SNPs certain provisions apply to, but I wanted to clarify that point. The other point that I wanted to clarify is that while the BBA-related provisions do apply, as directed by the statute, January 1st, 2021, there are a handful of provisions in here that apply sooner. They apply January 1st of 2020, so we'll point those out as we go as well. Okay, so I'm going to start off with the integration provisions and just give you a flavor for what, very high level, what we did in the CFR to make these changes. The Bipartisan Budget Act of 2018 authorized D-SNPs permanently for the first time since D-SNPs became available to beneficiaries in 2006. As part of the deal, though, it also established a variety of new requirements for D-SNPs, including specifically with respect to the integration of Medicare and Medicaid benefits. It raised the bar, so to speak, and those requirements will apply beginning 2021. In the final rule, we took the statutory language and tried to simplify that to create three pathways for D-SNPs to essentially prove that they meet one of these integration criteria. So there are three options here. The first two options involve some level of provision of capitated Medicaid benefits. So the plan will in some way have a contract with the state for provision of Medicaid-specific services like long-term services and supports and behavioral health services. There are two pathways here. The first is for the plan to qualify, meet the requirements as a fully integrated dual-eligible SNP, a FIDE SNP. And the second option would be for the plan to meet the requirements of a highly integrated dual-eligible SNP. And I'm going to talk a little bit more about what those terms mean, so I'll put a pin in that for now. And just also quickly mention, although Marna's going to go into this in a lot more detail than I will, that there is a third pathway. So for those plans that don't meet that level of integration and don't offer capitated Medicaid benefits, there will be a requirement via the MIPA contract to establish a process whereby the plan or some designee is sharing information with the state or some designee of hospital and skilled nursing facility admissions for some group of high-risk enrollees in the plan. Okay, so I know that talking about definitions is not very exciting, but it's really helpful to helping us set the context for how these requirements apply and to whom. And so I wanted to take a couple of minutes to discuss the different kinds of D-SNPs. There's been a definition of a D-SNP for some time now, and in the final rule, we streamlined that definition. The things that remain the same is that a plan that is a D-SNP may cover Medicaid capitated services, and it may not. So both options remain available, and a D-SNP has to have a MIPA state Medicaid agency contract. Those things haven't changed. We've obviously brought the definition up to date with the BBA requirements. And so starting 2021, one of these three integration options has to be satisfied by the D-SNP. But one of the other things that we did sort of beyond the BBA provisions is that we clarified in the D-SNP definition the statutory requirement that plans, or D-SNPs specifically, arrange for the provision of Medicaid benefits. Because we thought it was important to codify that language in such a way as to establish what that expectation actually means. And from our perspective, and sort of complementary to the integration provisions that we're establishing in this final rule, what it really means is coordinating the delivery of Medicare and Medicaid benefits. So more on this in a minute. I'm going to talk about how this complements a different provision that we established in this final rule. But first, I'll walk you through the fully integrated dual eligible SNP provisions, because this is essentially the pathway that is demonstrates, at least in the SNP world, the most integrated option for plans. FIDE SNPs have been around for a while. The definition has existed, and we have made some changes both to bring the CFR up to date and make it consistent with the BBA, but also to streamline some language and bring in some sub-regulatory clarifications that had not existed in the rules before. So what's unchanged about a FIDE SNP is that it is a D-SNP that under a single entity has both an MA contract with CMS to offer a D-SNP, and also has a contract with a state as a Medicaid managed care organization to provide Medicaid benefits to its eligible members. One of the clarifications we made, though, was expanding the language where we refer to long-term care services. We've expanded that to sort of include the sort of broader term of what a FIDE SNP should be providing, which is really long-term services and supports writ large, and that includes things like home and community-based services. And also, this is a sub-regulatory requirement that it existed in guidance but not in the regs. There is a requirement that the nursing facility services of at least 180 days be provided by all FIDE SNPs. Now, the HIDE SNP definition is new. There had previously been sort of this concept of a D-SNP with a high level of integration that had existed in regs and in guidance, and that really had been focused primarily on these plans' eligibility to offer additional supplemental benefits. So we haven't changed that, but what we have done is created a definition of what a highly integrated plan means and made that consistent with the statutory language. So compared to a FIDE SNP, a HIDE SNP offers some, relatively high level of integration, but obviously less than a FIDE SNP, and there are some key differences in terms of that integration level. The first that I would point to would just be the breadth of the services covered under the capitated contract. The HIDE SNP has the option of offering either LTSS or behavioral health services. It doesn't have to offer them both. The other major difference that I would point out is sort of the directness of the relationship between the organization that offers the D-SNP and then the organization that offers the Medicaid coverage. That can be more indirect in a HIDE SNP. So it doesn't have to be the same organization. It can be an organization that is under the same parent organization umbrella. So there are a few differences, but those I think are the two key ones that I would point out. This is a great chart. I'm not going to run through it line by line. It comes directly from the final rule preamble, and it compares FIDE SNPs and HIDE SNPs across a variety of attributes, including sort of the directness of that contractual relationship, the kind of Medicaid contract that the organization can have, and then also the specific benefits that have to be covered by these. So this spans over 2 pages. Again, it's really here for you as a reference. One of the really important definitions to understand, primarily as it relates to some of the unified appeals and grievances provisions that Mark and Toby are going to run through, is what it means to have aligned enrollment, right? So this is also a new concept, but it's one that we've been talking about in the dual space for quite some time. Aligned enrollment occurs when a dual-eligible individual is enrolled in both a D-SNP and also a companion Medicaid MCO that's affiliated with that D-SNP. Exclusively aligned enrollment is a subset of aligned enrollment, and that occurs when, as a matter of state policy, right, a state has made a decision, the D-SNP enrollees can only be enrolled in that companion MCO for their Medicaid benefits. They don't have the option of getting them through fee-for-service or another organization's MCO. They have to be aligned in order to be enrolled in that D-SNP. So it's relatively rare. We think that exists right now in about 8 states, and it's going to be really key for understanding how the grievances and appeals provisions apply. Okay. I'm going to wrap up just by talking about one more provision. As I mentioned earlier, in the final rule, we clarified that all D-SNPs must coordinate their Medicare and Medicaid benefits. So for beneficiaries who are entitled to these Medicaid benefits, it's important that the D-SNP be making those connections, regardless of how the beneficiary is obtaining those services. So some of those beneficiaries are going to be getting their Medicaid benefits in fee-for-service. Some are going to be getting their benefits through an MCO that's affiliated with the D-SNP's parent organization, and some are going to be getting the benefits through a different MCO altogether. Or it can be a combination of those 2, right? So we understand that that's complicated. But as a corollary to that, one of the things that we wanted to do to sort of undergird the unified appeals and grievances provisions and ramp up on the coordination requirements is to establish requirements that all D-SNPs provide assistance to their members with getting Medicaid-covered services to which they're entitled and resolving any coverage or authorization issues that arise with respect to those services. We also expect D-SNPs to provide assistance with filing Medicaid grievances and requesting appeals for Medicaid-covered services. So starting in 2020, this is a new expectation. D-SNPs are explicitly required to provide this assistance, and that should happen when the plan becomes aware of a beneficiary's need for a Medicaid-covered service. So we would expect D-SNPs to be having contact with their members in a variety of ways. So there will be health risk assessments and care planning processes, and as part of that, a member may be identified as needing a very specific Medicaid service, and so our expectation is that the plan is connecting the beneficiary with that coverage, which will involve asking questions about where that beneficiary gets their coverage and connecting them to those resources as necessary. So I think with that, I'm going to hand things over to Marna. She's going to walk you through the rest of the integration provisions.
Thanks, Vanessa. Starting in 2021, all D-SNPs that are not contracted as FIDE or high D-SNPs must include a notification requirement in their state Medicaid contracts. This requirement is intended to advance integration by improving care coordination between the D-SNPs and states during transitions of care, such as an admission to a hospital or a skilled nursing facility. And these are times when the coordination of Medicare and Medicaid benefits is crucial. Our approach in developing this requirement was to give states and plans the flexibility to implement this requirement in a manner that best meets their priorities and takes advantage of existing systems and infrastructure. We realize that not all states are in the same position to move towards greater integration, and flexibility in how states and plans can implement this requirement allows them to scale up integration efforts over time. The regulation we landed on was to require D-SNPs to notify the state of an admission or to a hospital or a skilled nursing facility for at least one group of high-risk, full-benefit, dual-eligible individuals. The D-SNP can determine or designate a provider, such as a hospital, to complete the notification. but will ultimately be held responsible for ensuring that notification happens. And similarly, the state may designate a recipient of the notice, such as a Medicaid managed care organization or Medicaid provider, or anyone who's able to act on that admission information. The state will also determine which subset of high-risk individuals the notice will be required to be sent for. And ideally, that will happen in collaboration with the D-SNPs within that state's market. I'd like to go back to that high-risk group of high-risk individuals. The state can choose those, can identify high-risk individuals in several different ways. They can be those who are receiving home and community-based services, or using enrollment information, identify beneficiaries who have frequent readmissions. And states can select a small subset of high-risk beneficiaries in order to create a notification that wouldn't require automation, and perhaps build that up over time. Alternatively, states that have a more developed infrastructure can use their state contracts to establish a notification for a broader group of beneficiaries. States will also establish timeframes and methods for the notification, but we, again, strongly encourage them to work with D-SNPs to identify the most efficient notification mechanisms available. And we encourage D-SNPs to reach out to their states to identify approaches to this notification requirement that enhances care coordination for all stakeholders. And as we'll be mentioning throughout the presentation today, we will be providing technical assistance and sharing best practices for this notification requirement as we gain more experience. And now we have a pop quiz to make sure all of those people who are sleepy are paying attention. True or false, all D-SNPs must notify the state of all hospital and SNF admissions. All right. Well, this was a little bit of a tricky question. It seems that most of you are getting it right. This was a double false, that D-SNPs that are not FIDE and HIDE SNPs will be required to include this notification in their Medicaid contract. So it's not all D-SNPs. And it will not be for all hospital admissions. It will just be for hospital and SNP admissions for that subset of beneficiaries identified by the state as high risk. Moving on, any D-SNP that does not meet the integration criteria that Vanessa mentioned earlier, being a FIDE or a HIDE SNP, or including the notification requirement in the state contract by the year 2021, will receive a market and enrollment sanction from CMS, and these sanctions will continue until the D-SNP submits a corrective action plan and the criteria of integration are met. And last part on contracts, we have another table for you to serve as a reference that just highlights some of the minor changes we've made to the contract requirements. These are mainly to improve clarity as well as to align with the new D-SNP definition. And I am now going to pass it on over to Toby Oliver to talk about D-SNP Unified Appeals and Grievances.
Thanks, Marna. Hopefully everybody that was sleepy after lunch has gotten their coffee for the grievance and appeals part. So the Medicare and Medicaid system, program systems for grievance and appeals have been separate, and there's been differences in the requirements between the systems historically. The number of differences has decreased over time. including with the Medicaid rule that was finalized a few years ago, but there's still a number of differences and there's still separate systems. And this has a direct impact on individuals who are enrolled in both programs to the extent that they need to appeal a benefit decision and they need to understand and navigate the two different systems. So the Bipartisan Budget Act of 2018 helps address this issue to some extent by requiring a unified grievances and appeal procedure for D-SNPs to the extent feasible as determined by the Secretary for 2021. So the way we've finalized the rule is that it will be applicable only to applicable integrated plans, as Vanessa mentioned earlier, and it'll be effective in 2021. Right. So some of the differences that still exist between Medicare and Medicaid that we were thinking through as we were developing this unified system include filing and adjudication timeframe differences. So for example, under Medicaid, an enrollee can file a grievance at any time, whereas under Medicare, they need to file a grievance within 60 days. Availability of benefits continuing while the appeal is pending. This is something that's available to enrollees only under Medicaid currently, where if a plan tells a beneficiary that they are going to reduce or stop a service early, the member can actually ask that the benefit be continued while their appeal is being resolved, and that protection is not currently available under Medicare. Also, the levels of review and availability of an expedited grievance. Expedited grievances are currently only something that's available under Medicare. It's not something that exists currently under Medicaid. So as you can probably guess, all these kind of really in the weeds differences can be confusing and harmful to enrollees and lead to duplication of activities if an enrollee files a case under an appeal under like Medicare and Medicaid for a benefit where really it's only appropriate under one or the other. So it can be duplicative activities for both the individual and for the plan. So the Bipartisan Budget Act had some details in it that we really used as policy principles when we were developing our unified appeals and grievance system. One of which is that we adopt the requirements that are most protective of enrollees. And so an example of how we did this is, as I mentioned earlier, the differences in filing requirements for grievances. In our unified system, we have set it up so that an enrollee can file a grievance at any time, like is under the current Medicaid standard, because we found that to be more protective for enrollees, that they can file anytime without having to worry about a deadline. The system needs to be compatible with unified timeframes and consolidated access to external review. So we've set up a one plan level of review for both Medicare and Medicaid services for the first level of review with one set of timeframes that applies to the whole process. We were supposed to take into account differences under state Medicaid plans, i.e. state flexibility. So this is another difference between Medicare and Medicaid currently. It's not something that really exists under Medicare currently, but under Medicaid, states can currently have different standards. There's the regulation standard under Medicaid, but then states can vary from that to some extent, typically by like shortening a time frame. Instead of giving a plan 30 days to respond to something, shortening it to only giving 14 days to respond on something. So those types of state differences. We were directed to take those into account. And then also that it should be a system that's easily navigable by enrollees. As we mentioned earlier, this is a unified system that will only be applicable to a subset of D-SNPs. It'll be only applicable to FIDE SNPs and HIDE SNPs with exclusively aligned enrollment and also applicable to the Medicaid managed care organization that's aligned with that HIDE SNP or FIDE SNP. So the most important takeaway is that it will only be applicable to plans that have exclusively aligned enrollment under state policy. So as Vanessa mentioned, there's currently only 8 states and 37 D-SNPs that would fall into this category. So a relatively small number of plans will be impacted to start, but we hope that it'll be a growing number over time. So next we have another polling question to see if you were paying attention. We should have warned you up front there would be tests. My organization operates at least one applicable integrated plan. So you have to have followed my definition and our description and also know what kind of plan you're coming from. Well, and being that there are only 8 states and 37 plans. We kind of expect the number not to be too high, but I'm impressed. There are more saying yes, we do than I kind of expected.
No, it was a selection bias, right? They're the ones who are paying attention.
That's true. You're the ones that are paying attention. That is true. So with that, I'm going to turn things over to Mark.
Okay, thank you, Toby. Well, if you're not awake yet, you'll definitely be by the time I am done the details of the integrated grievance and appeal process. I'm going to spend just a few minutes going through some of the details. Obviously, there's a lot more in the final rule and in the preamble, and if you haven't reviewed it already, we encourage you to, and there's going to be more guidance and other materials coming out. But basically, when you review the rule, you'll see we've set up specific language that borrows from both the Medicare and Medicaid rules and makes some harmonization to set up a single grievance process, as Toby alluded to. So we've unified the timelines and the grievance procedures. We've also integrated the coverage determination process and the plan level appeals process, and those are you'll see these are new sections of the CFR at 422, 630, 631, and 633. One of the reasons I think we are very optimistic this is going to be helpful for beneficiaries and plans is in this coverage determination and reconsideration process, the integrated plan applies both Medicare and Medicaid criteria. And if any of you have worked in this world, you know things like home health and DME in particular. You've got Medicare criteria, you've got Medicaid criteria. The member doesn't know which criteria applies to them. The idea here is that there's one consideration. The plan looks at both coverage criteria and determines if there is or is not coverage under one or the other. And because it's an integrated product, there's not the same level of confusion or concern. As well as there's one set of timelines, so the plan doesn't have to worry about am I on this timeline or that timeline, there's just one. And we set rules for who can represent and who are the parties, looking at some very nitty-gritty differences between Medicare and Medicaid, who can request an appeal and when. And we tried, and I think we succeeded finally after some very helpful comments during the comment process at getting a rule that brings together Medicare and Medicaid rules in the best way to protect beneficiaries and keep a manageable system. One of the areas where integration we think is going to make a big difference is in the notice area. The statute, the Bipartisan Budget Act, tells us that we need to have a single written notification of all grievance and appeals rights. We're working on developing model notices and instructions, and we're relying heavily on the experience we've had with the Financial Alignment Initiative. These are the Medicare-Medicaid plan duals demonstrations some of you may participate in, others have no doubt heard of, where we have been integrating Medicare and Medicaid now for, I guess, 2019, so 5 years. So we've relied a lot on the experience we've had in that, in starting to work on our notices. In particular, there will be one integrated denial notice that it's based in part on the current MA&IDN, but we're making some changes, and it's described in the reg at 631D1. The model is going to be beneficiary tested, and then it will go through the Paperwork Reduction Act process, which means everyone here will have, and everyone who is interested will have an opportunity to comment on it, and that will probably be this time later in 2019, right, Marna? That's the target. So keep your eyes out for that opportunity to comment on the model notice. We really want comments. We are trying to make this a beneficiary-friendly and functional notice, and we really want to make it as good as possible. We are biting the advice both from the statute, or the instructions from the statute, and advice we received from everyone to make it an easy, plain language notice, something that people can understand the status of their grievance and appeal from. So, again, this is an area where we are looking for help from everyone to make something that works for all stakeholders. One of the key areas, again, where I think this is a change from existing Medicare practice, and my colleagues already alluded to it, is the continuation of benefits while the appeal is pending. Just for a bit of context, since this is primarily a Medicare audience, the notion of benefits pending appeal is very well established in Medicaid. The idea is that if you have a service that is ongoing and your plan, or in Medicaid, it's often the state agency wants to make a change and a reduction. They give you advance notice, and you have, if you appeal within a certain period of time, typically 10 days of receiving the notice, you can keep that coverage going during your appeal. The idea being that someone with very limited financial resources is unable to pay out of pocket while an appeal is pending, and so the protection in the law recognizes that and says you can keep your services while you are contesting if the change in your services. And the statute directed us to carry that protection into the Medicare Medicare benefits, which are primarily limited to ongoing services. And so this is a big change in law, although I think at an operational level, based on our experience, we have done this in Medicare-Medicaid plans and the financial alignment demonstrations. Again, there are not that many ongoing Medicare services compared to Medicaid. In Medicaid, you think of things like personal care that goes on, and there's changes in your hours and things like that. Medicare, an office visit is not an ongoing service. You don't have, there's something, or a test that you're asking for a prior authorization is not an ongoing service. But there are some changes, and especially it will just simplify matters. You don't have to figure out if this is a service that I can get benefits continuing or not. This protection isn't going to be part of the model notices. It's something that our plans are going to have to think about how are they going to deliver. Again, it's something that if you have worked in the Medicare-Medicaid plan world, the financial alignment world, you're familiar with it. And those of you who have products in that area, I encourage you to look at their experience. We have not heard really any complaints from any plans in the MMP world about this provision. So we're hopeful it'll be a simple and helpful change. Finally, this is a short section of the regulation. 634 points out that subsequent to this integrated plan level review, all the Medicare and Medicaid review that we're all familiar with stays in place. So the appeals basically bifurcate after that point. We talked about in the proposed rule that we are interested in looking at ways to integrate subsequent to the plan level, but we've still got a lot of legal and policy challenges we've got to figure out. So for a Medicare-related service, after a plan level integrated review, it will go through the regular Medicare review of the IRE, and then if appropriate to an ALJ and possibly appeals council. Medicaid, the same state fair hearing rules exist and any other state rules. Okay, this is your last survey question. This is a question. The question is, all D-SNPs must adopt integrated grievance and appeals processes by 2021. It's a yes or no, true or false. All right, remember the question, I'll give you a hint. The question is all D-SNPs. And is it all D-SNPs or is it a group of D-SNPs? Yeah, now we're trending in a better direction. There you go.
States versus 50.
Right. So remember, we are talking about what we call in the rule applicable integrated plans. We'll have to adopt this, and generally there's about 8 states, about 37 plans right now. We think that number will probably grow. These are, as we talked about, plans where if the state requires enrollment in both the Medicare and Medicaid product, and we talked about this in both the proposed and final rule, we just could not get our minds around how you could do an integrated process if someone is in one plan for Medicare and either a Medicaid fee-for-service or a different plan for Medicaid. Someday maybe we'll figure that out, but this is where we're starting, and this is what we felt the best way to apply the statute was for now. Okay. That is all on appeals specifically. This is the wrap-up where we nag you to get started on your jobs. And we take turns doing this, so it's my turn today. 2021 is not that long from now, especially in the sort of policy and operational world. So it is incumbent on everyone who works in the D-SNP world, all of us at CMS, everyone in the states as well, to start planning now. If you have a D-SNP product, regardless of whether it's an applicable integrated plan, any D-SNP product should be talking to the states you work with. As Marna was talking about, there are these notification requirements where there's a lot of state flexibility. There's an opportunity for you all to talk to the states about what kind of notification makes sense, what entities should be notified. So, get in touch with the state Medicaid agencies. The revisions to the contracts have to be made by July 2020, so, not tomorrow. Not this year, because this is this year's contract, but as soon as this year's contracts are done, we are expecting, states and us and everyone to really start engaging on this. If you are an applicable integrated plan or you operate one, then there are operational changes you're going to need to make for these unified grievance and appeals procedures. So it's time to start thinking of what does that encompass. We are here to help. We are working on sub-regulatory guidance. There will be memoranda. We're going to be updating a number of manual chapters to reflect these rules. So stay tuned for that. We certainly want feedback on that as well. And some of you may be familiar with our contractor, the Integrated Care Resource Center. If not, I certainly encourage you to check them out. Their target audience is states, state Medicaid agencies looking to integrate. A lot of the information is extremely relevant to all of you who operate D-SNPs as well. We're working with them to provide states and as well as to you with best practices for sharing information, as Marna was talking about. What do we do this information about inpatient and hospital admission? Where should it go? Who should use it? What's the best way to use it? What's the best practices for getting D-SNPs information about enrollees' Medicaid coverage? We know during the comment process we got a lot of comments saying this is very difficult in a number of states, and certainly we look forward to making that better. We're going to be working on model contract languages for your state contracts, and states can get technical assistance there as well, and they put out a lot of great materials, so I encourage you to look at them. I think we provide, the link right here. So this is just for further investigation. We have the text of the rule there. I encourage you all to look at that if you haven't already. The Integrated Care Resource Center ICRC website is there. Definitely take a look if you haven't already. And then questions you can send to us. And I think that is all, right? And we have 7 minutes for questions, so we're great.
All right, we do have a couple minutes for questions, so if there's anybody in the audience that has a question, please go ahead and step up to the microphone, tell us your name and where you're from. Bless you.
Hello, I'm Sarah Triano with Centene, and I have a question. I have 4 questions, but I'll wait. I'll get in line after everybody else does. In geographies with overlapping MMPs and D-SNPs, which takes precedent, passive enrollment into the MMP or default enrollment into the D-SNP?
I'm not sure I got the question.
So if you have a certain geographic area where you have D-SNPs that exist, but you also have an MMP.
Yes.
MMPs have passive enrollment.
Yep.
And if that D-SNP has in their contract is allowed to do default enrollment, which one takes priority?
So,
Who gets the member?
so that's really a state decision. So the state has to provide approval, for default enrollment into any D-SNP. And they also work with us in terms of passive enrollment into the MMP and where they will be drawing from. So it's contingent on the state.
No, you're right. I completely agree. States have, and we work with states. If a state decides to exclude, say, D-SNP enrollees from passive enrollment, we can do that. We've done that in a couple states, I think. And then, so it's something that we work out with the states. Some states have permitted it, but have they drawn from D-SNPs? I don't think anyone's drawn from a D-SNP, but like Illinois decided basically to push everyone towards MMPs, and that's permissible as a policy decision, but it's done deliberately. It's done in consultation with CMS.
Okay. I think you're up again.
Okay, I'll keep going. I really appreciate the efforts to integrate the grievance and appeals process. My question is CMMI or CMS doing any kind of test, anything to test the alignment of the assessment process, particularly for unaligned duals?
Assessment. Like the health risk assessment?
Yeah, or for, say, somebody who's receiving Medicaid MLTSS, where they go through a very extensive assessment process. And there's also assessments, that part of the coordination required for D-SNP. So is there anything to kind of align that better so that those members are not going through multiple assessments,
So-
the ones who have chronic conditions.
So I understand the issue, and it's on our plate. It's complicated to address because plans have specific needs for their health risk assessments, and states also have certain requirements. But we're well aware of the problem. But it's not easy to solve because of all the players that are out there. But we would be happy to talk to you more about any ideas that you have along those.
Sure. That's on our wish list.
You're still up.
Okay. I have one last question, and that is, do the interoperability proposed rules also apply to D-SNPs? PACE organizations are exempt. Just wondering if D-SNPs are exempt as well.
So I'm not sure we have the right folks here to discuss the interoperability rule, which is, I think, currently still in a drafting stage. So you can send us that question, and we can try to find an answer, but.
Okay, thank you.
And we do have another question.
Hi, Michelle Ford at Medicare Compliance Solutions. So for all the D-SNPs who do not fall under the 8 states and the 37 plans, are there any efforts to help those members navigate the really confusing appeals and grievance process currently?
Well, I mean, and I think we talked about this, the D-SNPs under their obligation so those D-SNPs that they don't have all their members also in the same Medicaid plan, they have an obligation to help coordinate those Medicaid services, and that includes an obligation to help, their members to navigate the Medicaid process, Medicaid grievance process, Medicaid appeals process to get, and to figure it out. It's not enough for them to say somebody seeks a Medicaid benefit and they only provide Medicare benefits. It's not enough for them to say, sorry, we don't do that. They have to help their member access those benefits.
Gotcha. And then a second question we have is, is CMS working with the states to allow more MA&PD plans to have Medicaid contracts?
So well, what we're doing through the Integrated Care Resource Center is to provide states with information on the benefits of integration, including integration on the D-SNP platform. That is, you get somebody, if you're using managed care for delivery of your Medicaid benefits, in particular managed long-term services and supports, there are real benefits from integrating that with the provision of Medicare benefits. So the medical and the long-term care are integrated. But it is up to the state to decide if they want to go that route and whether they want to contract with a D-SNP or not.
Right. I mean, there's some states that are not going down the managed care path as much on their Medicaid program, and so they need to look at different models for integration. And we're eager to talk with them too, but this is not the platform from them.
Right.
And that's okay too. We have 50 states.
Yeah, thank you.
Okay, well, we are out of time for questions for this session, so I would like to thank our panel for the clarification on the new rules related to D-SNPs. Thank you. All right, so if you'd like to evaluate this session, go ahead, take those phones out and enter A, send, and then go ahead and follow that link.
Okay. We're going to give this an 8.
And enter your responses. While you are doing that, I will introduce our next session. Our next and last session of the day is what we call our open Q&A session. And during this time, we are going to have all of our speakers from today join us here on stage. And we will go through each session and give you one last opportunity to ask any questions that may have come up for you throughout the day. And at that time, too, for our viewing audience, we will address any of the questions that you sent in to us via the Ask CMS Live survey. Any questions that we don't have time to respond to, we will actually prepare responses for those, and then those will be posted on the CTEO website at a later date, and you will receive an email when that information is posted. So at this time, then, I would like to ask all of our speakers from today to join us here on stage and have a seat, and we will go through our questions with you. Okay, so we will start with our first session of the day, which included Richard Jensen and Sharon Andres. And we did receive a couple questions from our virtual audience, but I would like to open it up to anybody in our live audience first. And if you do have a question, please step to the microphone in the center of the room. Okay, so we will go ahead and we'll jump to the questions we received from our virtual audience. And the first question is, and this is going to Richard and Sharon, what if the plan doesn't have payment arrangements with providers that meet the APMs? If you could speak it, there you go. It should be on.
Is this on now? Could you repeat the question, please?
Absolutely. The question is, what if the plan doesn't have any payment arrangements with providers that meet the APMs?
Well, the payment arrangement is either an APM or not. But I think what they're saying is if their providers are not involved in either APMs or advanced APMs, our discussion is not relevant in that sense because as I was saying during the presentation, your network is only going to be interested about getting advanced APMs and becoming QP status if they're at least significantly involved with Medicare advanced APMs and therefore the all-payer. For clinicians that are not in APMs or advanced APMs more specifically, they are going to be in the MIPS program, and that's how they're going to be reimbursed under Part B.
Okay, thank you. The next question, if a provider is identified as submitting an inordinate amount of claims identified as improper payments, how does that affect their ability to be a qualifying participant in MIPS or advanced APM?
I'm not a program integrity person.
Okay.
That in and of itself, I don't know what the relevance is per se. I mean, could you repeat what they said, that they're inappropriately?
Sure. If a provider is identified as submitting an inordinate amount of claims identified as improper payments, how does that affect their ability to be a qualifying participant in MIPS or advanced APM?
I don't know. That's a program integration issue I'm not familiar with. They're going to be in trouble, but I can't tell you how.
Okay.
There's nothing about our discussion of whether you're an IPS. Pardon me? Well, that's certainly true. The claims wouldn't count towards their QP status, but they wouldn't count for any purpose whatsoever, it sounds like. So.
Okay, we'll move on to the third question we received, and that is, please clarify the new gap on name brand medicines.
That definitely has no relevance.
Okay, so I'm not doing so well here today. All right, so any other questions for session one? If not, we are going to go ahead and move to session 2 to John Booth. Okay, hopefully I'll do better this time. All right, regarding the tool that helps users decide what type of Medicare coverage is right for them, won't the results change based upon current diagnosis or health needs? And how can this be addressed for the beneficiary?
Yeah, it's a good question. They will change. And so one of the things that we built into the out-of-pocket cost calculator that we launched last year is the ability for people to select health status, so good, fair, or, average, good, or poor. And then based on that, they will see the projected cost change significantly. That's a model we're looking to refine and move forward. And I talked earlier in the day about using personalization, so we're looking to see if we could be able to actually identify some of that about a beneficiary knowing that they have, say, a chronic condition. We could maybe pre-fill that for them. So that's sort of a future thing we're looking into. But yes, it does have a big impact on the potential out-of-pocket costs.
Okay. All right, I got a good one. Moving on to the next one. We appreciate the efforts by CMS to improve the MPF. Regarding improvements to information about annual costs, will CMS share with plans information on how CMS calculates the plan and drug costs so that plans can better validate that the information is accurate?
Yeah, so one of the, we talked earlier in the day about the part of the current Medicare Plan Finder platform is a proprietary engine, so it's not intellectual property that is CMS's. In the new tool, that pricing algorithm is something that we will own. And so we are looking to publish more information about that and to be more transparent about that moving forward. I will mention that a lot of the source of the drug information, the lists of the drugs and mapping commercial drugs to generics and those sorts of things, those are commercial data sources. So that's not necessarily stuff we can release into the public, but the algorithm itself is something we do plan to publicize and make available so people have a better insight into how that works than they do today.
Okay. Any questions for John out there? Please step to the microphone.
Hi, Matt Dobson from Care First Blue Cross Blue Shield. You mentioned in your slides about better integrating Medigap into the Medicare Plan Finder. Do you have any specifics on that?
We don't have a lot at this point. Medigap data is something we've been doing a lot of research on, and there's the data is sort of collected manually today. We're talking with organizations that do collect that data. We know NAIC collects it. But the data that NAIC collects is actually sort of 1 year behind the current year, and so that's not optimal for us to use in the tool. So I don't know that we have a lot more to say at the moment, but we are beating the bushes to figure out as much as we can and getting good and timely sources of that data so that we can integrate it more into the tool. Thanks.
Okay, thank you, John. We are going to move on to our third session, and Lori McWright is with us here today to answer those questions. And if you have a question, our in-house audience, please step to the microphone. And if not, I will move forward with our virtual questions. Okay, the first one I have here. I would like to know more about how access to telehealth will change in 2020 and 2021. Will we be able to use telehealth services in an urban setting and not just a rural setting? Can patients have a video-supported visit from their home, and can we capture codes via telehealth?
Wow, lots of questions all at once. So first, in fact, the 2020 plan year, the telehealth network is an option, as I described earlier today. It can be used not only in rural settings, but also underserved areas, which could include the urban areas. In addition, keep going,
Can it be video supported from their home?
Yeah, and so really we leave it to the plans in proposing a variety of interventions related to telehealth. And I think what we put out in our RFA as just general guidance was the idea that it be clinically appropriate for the specialty, and that it be supported by evidence out in in the world that it makes sense. The best examples are things like you're obviously not going to be doing telehealth when you're doing bunion surgery, or the idea of what you could see, a beam me in visit in a home, what clinically makes sense there. And so we left it to the plans to propose interesting ways of using it.
And the third part was, can we capture codes via telehealth?
Well, that's really a payment issue that would be between the Medicare Advantage organization or plan with the providers. It's not, CMS wouldn't be directly involved in that.
Okay. All right, Lori, the next question. For the 2021 model, is the idea that the MA plan would create a hospice provider network?
As Gary described, that's a great question. And, basically, I think the concept that we're looking at is that there would be, as with all provider groups, that there would be an in-network contract with a set of hospice organizations, but that it would also extend to the concept that there would be out-of-network coverage as well.
Okay, and the second part of that question was, how will the MA plan be reimbursed for associated costs?
Another great question. I was surprised it didn't come up this morning, actually. So in essence, the current rate book for MA organizations obviously does not include hospice because it's not carved in. And so we're looking at various strategies of how we might develop rates that would be inclusive of hospice. And, just thinking about what's possible, where the current methodology, including risk adjustment, et cetera, doesn't necessarily cover where we are now in terms of thinking about hospice. So that's a work in progress, and definitely more to come on those pieces.
Okay, next question. Lori stated that the annual limit for rewards and incentive programs will be up to 600 and includes Part D benefits. Is this limited to rewards and incentive programs only for VBID programs and benefits, or does it cover all MA programs regardless of VBID participation?
Yeah, another great question. Yeah, that would just be related to VBID participants.
Okay, and the last question I have here, how many plans submitted VBID applications for 2020?
Thank you for that question. And right at the moment, we're reviewing all the applications and the updated information we got last night. So really not at liberty to be able to say a whole lot about that. But more to come, in the future. And very excited to share all of the information.
Okay, and then we're going to move on to our last session of the day. So I'd like to invite any of our in-house guests to step up to the microphone if you have any outstanding questions. And if not, I'll go to the question we received from our virtual audience. And that question is, can a FIDE identify specific populations as high risk? If so, does this require a separate product, meaning identified as two separate D-SNP types requiring separate contacts?
I'm going to take a stab at that based on what I think I understand about the question. So it's the state determining what a high-risk enrollee is. And I think Marna provided a couple of examples in her presentation about ways in which states might mine their data to, or consistent with their goals, identify who is high risk. But then they would specify those high-risk populations in their contract. But I just want to clarify that the FIDE SNPs are not required to report the SNF and hospital inpatient admission information. That's really for plans that are not FIDE or HIDE SNPs. I just want to make sure that folks understand that.
Okay. All right, well, if there are no other questions from our in-house audience, those are all the ones I received from our webcast viewing audience, so I would like to thank all of our speakers today. You guys may head down if you would like. Although you're welcome to stay up here with me, that's fine too. I'm okay with that. All right, so one last time to evaluate this session. So if you'd like to evaluate the open Q&A session, please go ahead, take out those phones, and enter A. Hit send and follow the prompts, please. Okay, and just a reminder, this conference will provide participants with the opportunity to earn CCB CEUs. So to obtain those, please complete the CMS attendance survey that can be found on the participant survey instructions that are posted on the CTEO website and also on those cards that we left at your table. If you would like to evaluate today's event, go ahead and, enter A, and then follow the link, and that will take you to the participant survey to evaluate today's event. If you did not participate in the polling today, but you would like to provide your feedback on today's event, a link to the event survey will be emailed to you, or you can connect to the survey using the QR code that was given to you at registration, or you can go to that participant survey instruction that's on the CTEO website and follow that link or that QR code to get to the survey. So pretty much that wraps things up for us today, and I would just like to thank all of our presenters for taking the time to prepare for today and the dedication to do so. We appreciate everything that you do. And of course, all of our in-house guests and our webcast audience for your participation today. Thank you, everybody. That concludes today's event, and have a wonderful evening.